Good morning.
Hi, Andrew. This is Leonard Altman.
Yeah.
Thanks for joining us this morning. Our audience will be growing over the next couple of minutes, and we'll give them about 10 minutes to join us.
Got it. Let me see if I can get rid of my glare here on my screen.
Glare on the screen from the sun is not something we worry about in Seattle this time of year.
So is your son Matt?
Yes, he is. You know him?
I do, yeah. And did you have a daughter who applied to Allergy recently too, a couple years ago?
Yeah,
Yeah.
she may be listening as well. She's in our program here in her second year.
Oh, great. Yeah, I think we interviewed her back a while ago. So, well, excellent. Yeah.
How's the day in San Diego starting off?
Great. It's been it's a pretty spectacular time of year for us usually, so can't complain. It's nice when we're trying to be outside so much that we've got good weather. I know it's not the same for you.
Does your program also coordinate with UC San Diego? Bruce Zura is a good friend of mine, and Mark Riddell.
Yeah. Yeah, Mark's the program director for their fellowship, and then I'm the program director for ours, and we do our weekly conference, academic conference is joined with them, which is nice. And then a lot of our fellows do research experience with them. So it's been a pretty great collaborative experience. And having Bruce, previously had his foundation at Scripps helps to keep our, paths a little bit more connected.
Is Ron still working full time?
He's backing off a little bit. He's he does Tuesday through Thursday now. And then at least before the pandemic, he was, going down to their place in Mexico quite a bit on the long weekends. And then he's got some grandkids in Texas. So he and Marilyn have been traveling a lot more.
How many fellows in total are there in San Diego? Fellows in training?
We currently have 5. So UCSD does 1 per year, and then we have funding for 3 total. So we end up having 2 on an odd year and then 1 on the even years. Yeah, that's good. And do you guys just have the UW program? Is that your?
Yes. Yeah, this is the only academic medical center. At other levels, like just internal medicine training or primary care, Virginia Mason, I think, and maybe even Swedish have training programs, but the only one with fellowships is the University of Washington.
Interesting.
And until recently, it was the only medical school, in a 5-state region. We have
Crazy.
Washington, Idaho, Montana, Wyoming, and Alaska. Now WSU, Washington State, started a medical school in the eastern part of the state.
Okay.
The UW was not too happy about that. It's kind of mean-spirited. They didn't really welcome another medical school.
Oh, interesting.
Yeah, well, because I think, means this is a state school up here, so it means competing for state funds.
Oh, right.
Everything in life comes down to money.
That's true. Yeah. gonna pop over it real quick. Give me a second.
Hey, Lynn, can you hear me?
Drew?
Yeah.
Yeah.
Looks like we're good to go here.
Well, we only have 13 people. I assume the audience will grow in the next couple of minutes,
Sure it will.
but everything else looks good. Are you seeing patients in office down there, or are you doing telemedicine?
We're doing about 50-50. We all have 1 day a week that we stay home completely. And then we try to do most of our first consults in telehealth. Just mostly to try to keep the waiting room a little less crowded, right? Because we've already got the shot patients and Zoller patients coming in. So it's been working out okay. Not great, obviously. How about you guys?
I don't know, Drew, you may need to speak for the university. My concern is that with things getting significantly worse, whether we're going to have to go back exclusively for a while to telehealth. Drew, what's the plan in the university clinics?
First off, hey, Drew, how you doing?
Yeah, hey, Drew. Nice to see you.
Good to see you. I'd say we're about 20 to 30% telemedicine, although the past few weeks that's really kicked up. We were almost exclusively in person for a while, but no, it's gone the other direction the past few weeks for sure. So I was looking at my schedule today. I have a lot more telehealth than I normally do. So I think we're swinging back in the other direction here. How are things down in San Diego?
You know, it's not, I mean, our counts are going up like everyone else, I think, but they seem a lot more manageable. And I do feel like we've got a little bit of a, you know, safety valve with being able to be outside. You know, the weather's not too bad. So I don't know, we'll see. But yeah, the hospital, I mean, every day you look at the counts and there are just more and more people in the hospital.
All right, well, it looks like it's 7 o'clock, so we can go ahead and get started. A colleague from Scripps, Andrew White, is kind enough to get up and join us this morning. And actually, it's the second talk in 2 weeks with now a medical perspective on aspirin-exacerbated respiratory disease. You'll recall 2 weeks ago, we had a colleague from ENT give the ENT perspective on this. So let's go ahead. Thank you very much. It's all yours, Andrew.
Great. All right, let me share my screen here. I'm happy to take questions throughout if you want to interrupt, or we'll hopefully save some time at the end. And I'm definitely sorry that I missed the lecture a few weeks ago. I'm always really intrigued and interested in the ENT perspective on this. But yes, I'm going to hopefully talk to this from a medical perspective. I'm very interested in AERD. As you probably know, Scripps has had a big hand in sort of furthering what's going on in our understanding with aspirin desensitization. I took over the research program about a decade ago. And one of my main interests is how do we find these patients, and is it important? Is the endotyping or phenotyping of this particular subtype of severe asthma and sinus disease, does it really matter? My bias obviously is that it does. These patients, the purpose of this slide is I think these patients are hanging out in front of us, right? They're hanging out in front of our colleagues. We're looking for them, and yet sometimes they show up, you know, right in front of us without us even knowing. All right, so I do have several disclosures. Many of the products that are now approved for polyps and severe asthma, I have some potential conflicts with, so I will try to point that out as we go through the slides. So I'm going to hopefully illustrate this with using a few case examples. So these are real patients. This is a patient of mine several years ago, 40-year-old female, had a history of recurrent nasal polyps and asthma, had surgery twice in 6 years, and her allergist had been having a lot of difficulty preventing polyp regrowth. This was in the pre-biologic era. She now needs another surgery, so her third surgery in 6 years. She can't drink alcohol because it causes nasal congestion and asthma symptoms, but she takes NSAIDs without difficulty for joint pain. And so the question is, does she have AERD? Is it possible maybe she could have AERD or will develop AERD? And then maybe a bigger question is, does it matter? So I'm going to go a little bit quickly through the front part of these slides. You all, I think, are very familiar with the disease state itself. So AERD, it's characterized by chronic eosinophilic rhinosinusitis, nasal polyps in all patients, asthma in most. The hallmark, which is also required in all patients, is a reaction to aspirin or NSAIDs, causing rhinitis or respiratory symptoms for the most part. And this in general is a progressive disease, despite avoidance of NSAIDs and aspirin. I've heard this less often, but we still hear patients who are sort of told they should avoid salicylates or avoid taking NSAIDs as a treatment for their disease, which is inappropriate. The typical patients usually present in their 20s to 40s. Unfortunately, some of them will have had a decade of symptoms before proper diagnosis, so they may present in their 50s to you. A lot of them will describe being previously healthy and then this progressive development. The order doesn't matter a whole lot, although it usually starts in the sinuses, but some patients will start with their asthma. But ultimately, they sort of complete the triad over the course of several years. And a lot of patients, about 50% of patients from Andy Chechlik's report back in the 90s, was that they described having a virus infection that never went away. And we don't know if that's necessarily truly a virus or just what AERD feels like when you first develop it. But it's an intriguing possibility that there's a viral trigger that sets this in motion. We know that a lot about the NSAID reactions. So anything that inhibits COX-1 is going to cause a reaction. It's not IgE mediated, so sensitization doesn't matter. In general, COX-2 inhibitors are going to be tolerated. And acetaminophen is usually well tolerated, although at higher doses, people can have reactions. They tend to be more mild, although I've definitely had a few patients where it's been a little bit more severe. And I had a question also about the refractory period. So the refractory period, we tend to tell patients 48 hours to be on the safe side, meaning if they go more than 48 hours between doses of NSAIDs, they will react again. If you looked at that old study where Don Stevenson and Ron Simon described this back in the 80s, the refractory period really goes out to about 5 days. So a lot of patients have this gradual recurrence of their NSAID sensitivity going over 5 days. So if it's, you know, a patient of yours who had a relatively mild reaction in the past and they were desensitized and it's 3 days out from their aspirin, probably safe to just have them come in the clinic and take a full dose under observation. After 5 days, though, you do need to think about re-desensitizing them. I'm not going to spend as much time talking about the pathophysiology, but I do want to just orient to a few important concepts. I think the group's probably very familiar with the braking effect of prostaglandin E2. So if you look at the right column here, this is what's happening with aspirin dosing in AERD. You're going to have blockage of COX-1. you're going to have a downregulation of prostaglandin E2, which is going to have a braking effect. That's going to lead to formation of leukotrienes, among many other factors. And the important part here is that these leukotrienes are happening maybe more upstream than we think of. That they themselves are going to be going to the respiratory epithelium and leading to danger and alarmin release. We always think of alarmin release as happening first, and then the leukotrienes happening downstream. But this is important. And then as this process gets going, you can see that you're going to lead to more leukotriene production and potentially this feed-forward loop. And this is also illustrated here, where you can see at the top that the leukotrienes are playing a very high upstream role. So we know that this is a disease that's really characterized by dysregulation of the arachidonic acid pathway and leukotrienes specifically. So you can see that here. Some other important players, we know that ILC2 cells are very important. They are very potent in their production of cytokines, IL-5, IL-13, so have a big role in eosinophil trafficking. We know from the work at Brigham with Tanya Laidlaw that adherent platelets probably have a big effect in magnifying the production of leukotrienes. We now know that the leukotriene cis-LT3 receptor has been described as this previously named GPR99, which also probably has its own unique effects. So a lot of potential pathways and targets for treatment here. But I'm going to mostly spend my time going over clinical aspects. So we know that that this is primarily a disease where the epicenter is in the sinuses. So these patients tend to be worse than their non-AERD peers. Their sense of smell is worse. When aggressive polyp formation has been reported, it's almost exclusively in AERD. So here's a patient with polyps that are actually intracranial. This is a patient of mine where the polyps actually had erupted up through the internal auditory canal and ruptured out through the tympanic membrane. Patients that have AERD will require up to as 10 times as many surgeries as their non-AERD colleagues and have much higher rates of polyp recurrence at 6 months. And then for asthma, I think 10, 15 years ago, this was really thought more to be a syndrome of asthma. We know that in general, asthma is much more severe in the AERD population, but not in all patients. And I'm sure you all have patients who really have primarily just sinus disease and their asthma is easy to control or relatively mild. But in general, if you look at the populations of severe asthma, it is enriched for AERD. Those patients are more likely to have severe exacerbations and more likely to require systemic steroids. And this is, I think, everyone would agree, what the trajectory is for most patients with AERD. We find these patients at some point in their journey when they make it to an allergist. This line here is their line of anosmia, where they cannot smell. And so a lot of them will have had surgery, they have a brief improvement in their symptoms, they regain their sense of smell, they feel great, but unfortunately things start to come back, sometimes over a couple months, sometimes over a couple years. They start to get recurrent steroid bursts, asthma seems to worsen in parallel with sinus disease worsening, they get to a point where they need surgery, and the cycle repeats itself. So our job as allergists is to try to help break this cycle, right? We've got the important role of the surgeon in this, but this is a medical illness that requires a medical anti-inflammatory therapy. I'm not going to spend any more time on this other than this slide, but there's more and more data now coming out about heterogeneity in AERD. And if you had asked me many years ago, I would have said that this is not the case. This is, a highly type 2 disease. All patients are homogeneous. It's a great population to study from that standpoint. But now there's actually several studies and a couple coming out just in the next month or two that are in press that really show there's a pretty significant difference in some of the immune markers as well as the clinical characteristics. So this particular study, this was latent class analysis. They described 4 different phenotypes. They looked at patients that had more moderate symptoms, lots of upper airway symptoms. These patients had very high blood eosinophilia and had the highest urinary leukotriene E4 levels. There was a group that had much more mild asthma that was much more likely to be male. This group 3 patients had really severe asthma, and many of them had an ICU stay for asthma. And then interestingly, this class 4, which were in this group, all female, mostly obese, had childhood asthma, very poorly controlled asthma, but mostly normal lung function. So it's intriguing to start thinking about AERD in terms of its heterogeneity, and that may be important ultimately in how we treat them. We don't know, I don't think yet, how this would factor into treatment responses, but hopefully we can begin to use this to identify patients that may be more, maybe better targets for biologics or aspirin desensitization. The use of aspirin treatment in AERD has and continues, I think, to be somewhat controversial. But we now have 4 double-blind placebo-controlled studies that are all positive in terms of the effect on asthma. And this is a challenging group of patients to do a double-blind placebo-controlled challenge in, because you're including an aspirin desensitization in part of their study. And so blinding that or doing a sham desensitization obviously is fairly difficult. So if you look though over the theme of this, you can see that when it's really properly looked at, we see that aspirin therapy leads to an improvement on the sinus outcome, but less pronounced of an effect on the asthma. And that makes sense because this is primarily a sinus disease. And I think more and more of where we're going with this is that the sinus problem is driving the asthma. So to the people who say that all we have are poorly controlled case series to show the benefit of aspirin, I would rebut that not only do those for the most part show benefit, we also have these double-blinded studies. So one of my interesting questions is how common is this condition? When I was a fellow, I actually wrote a paper with Ron Simon and had cited this article in terms of the prevalence. This is a British Medical Journal article from the early 2000s. And this was the only systematic review at the time. And they said that the prevalence of aspirin-induced asthma is 21% for adults and 5% for children. And so I blindly cited this study, and Ron Simon came walking down the hall and he was basically like, do you honestly think that this is true? And when you stop and think about it, it's like, no, it's not 1 out of 5 patients with asthma have AERD, and certainly not 1 of 20 children with asthma have AERD. This is a disease that basically doesn't exist in children. So I became more interested in this, and several years ago, we decided to do another meta-analysis. And I realized how challenging this is. How do we find these patients? If you're looking at a group of asthmatics at Scripps Clinic, you're going to certainly have a bias of an enriched population for AERD. How do you determine it? Do you just say it based on history? Do you require there to be evidence of polyps, which we really don't think AERD would exist without evidence of polyposis? Do patients get challenged? And then are we including patients who may have been on different therapy like montelukast, which may block some of the reactivity? So we actually decided to look at this and report it out several different ways. And basically the range, if you're just looking based off of history or questionnaire, where it seems pretty accurate with the questions that they were asking, maybe 5 to 7% of patients based off of history studies would have AERD. If you start to include some challenges, and so you take patients that are at high risk, so potentially patients that have asthma and nasal polyps, and you have them come in the clinic and do a challenge on those, you start to see a higher prevalence, up to 12%. In the tenor studies, if you look at patients with severe asthma, it's as high as 15%, and then right around 10% in the population of nasal polyps. Now, we obviously know that the prevalence is much higher if you're starting to include patients with severe asthma and nasal polyps, where it might be as high as 30 or 40% in that group. And the one interesting exception here is actually one of the best studies that was done, and this was done in China. This study, they looked at 350 consecutive patients with CRS. 309 of them had nasal polyps, and they had all of them undergo an aspirin challenge. It's one of the only studies that's really looked systematically like that in the polyp population. And they only found 2 patients with a reaction. So very, very low, an order of magnitude lower than we would have predicted based on the other studies. And it's interesting, I think this makes sense given the data that's come out with some of the global studies on heterogeneity in polyp disease, where there seems to be much more of a Th1 bias immunologically in studies looking at China versus Belgian or the Northwestern group. So it potentially makes sense. And interestingly, at least their early report is that effect seems to persist into 2nd generation Asians living in the US. So if 5 to 10% of our asthmatic and nasal polyp patients have AERD, how do we find them? So we know that based off of history, we're gonna have some trouble. So about 15% of patients that we think have it will have a negative challenge, and I'll go over some of those might still have AERD and we're just missing it with the challenge. But also importantly, about 15% of people who don't think they have it, if you have them come in and challenge them, will actually have a positive challenge. These numbers probably sort of cancel each other out in terms of estimating prevalence, but for the patient in your office, there's a bigger chance you're just gonna miss it if you just ask the patient, can you take aspirin, right? And unfortunately, we don't really have any other diagnostic testing. So I'm going to spend a little time here going over factors that you should incorporate into your decision-making as you think about these patients. So the history isn't perfect, but aspirin challenge is 100%, right? So that's not correct. I'm going to show you a great case. This is my second case I want to show you. This is a 48-year-old male, had polyps and asthma diagnosed in '96. He's had polypectomy every 3 years, now for a total of 7 polypectomies. He's on budesonide washes, he's on Advair. He can't drink alcohol. Because of respiratory reactions, he was told in 1996 because of this that he should never take NSAIDs. And so the only history I could get is that he had been in the ER several years ago and had gotten some sort of IV pain medicine that he thinks was not a narcotic, so possibly ketorolac, and at that time didn't have a reaction. His FEV1 is 45% with obstruction, FeNO is 48. So the question is, how likely is it that he has AERD? Well, if we take that NSAID reaction out of the equation and potential NSAID reaction, you'd say, well, this is very high likelihood to be AERD. So we had him come in and do a challenge, and really nothing happened. This is our flow sheet that we use. So this is nasal inspiratory flow, really not much difference. Here's his FEV1, also not much difference. He did have some mild symptoms, very mild nasal congestion after the 2nd dose. We used nasal ketorolac in him. After the 60 milligram aspirin dose, again, a little bit of a drop. All of it was very subtle. Nothing required treatment. And this was really only me going back at the end after he followed up to try to see if I could, tease out any reaction. Because as we do with some of these patients, I was pretty convinced. We sent him home on aspirin just to see how he would feel. And he was a great example of someone who came back a month later and he says, quote, "I feel like I'm on prednisone." And here's his pre and post desensitization SNOT-22 score. So before we did the desensitization, SNOT-22 score is 53. And then 1 month later on aspirin, he's now scoring 12. So, and minimal important difference is 9 points. So it really seems like he is getting quite a bit of benefit from AERD, yet really had a negative challenge. And I can say that this probably happens, it's evolved over the decades. If you look back in the 70s and 80s when Don Stevenson, Ron Simon, Dave Matheson were doing a lot of these, there were no leukotriene modifiers. I think asthma control was less successful. And challenges ended up being much more severe with some ending in near intubation. But then in the 80s and 90s, desensitization protocols were improved. We're starting at the equivalent of 30 to 40 milligrams of aspirin. Then in the 90s and the 2000s, we have the addition of the leukotriene modifier drugs. And then in the later 2000s, now we've incorporated some different protocols. We're a little more protocolized in having all patients on leukotriene modifier drugs and ICS and LABA. So this was a paper that I worked on when I was a fellow, where we were really just looking at how being on a leukotriene modifier would modify what happens during the desensitization. And we were more interested in what was happening on the right side here. We were seeing less of these big drops in FEV1 in patients that were on a leukotriene. So it's offering protection for the lower airway, not a big surprise. And we looked here at the patients that ended up having a completely negative challenge. And if they were on a leukotriene modifier drug, they actually had more positive challenges. So we took that to say that the leukotriene modifiers weren't blocking the reaction in any significant way. You're actually more likely to have a positive challenge if you came into us on montelukast or zafirlukast. But in retrospect, that's probably not true. This is not a randomized trial. And so these patients were actually coming to us, and we just kept them on whatever they came in on. And so perhaps these patients, because of their response to montelukast, stayed on it, and it sort of biased them towards being more likely to have AERD. We saw the same effect even when you looked with systemic steroids in the mix. So even being on systemic steroids and a leukotriene modifier drug, you're more likely to have a positive challenge, just less likely to have a very severe drop in FEV1. So back at this time, which was in 2006, we had reported on this and basically put in our paper that we don't think that leukotriene modifier drugs are going to block the reaction in any meaningful way. But there was a hint already that we were wrong. This was a study also out of our group that Don Stevenson did. This was looking at 10 patients who underwent an oral aspirin challenge. They then came in on montelukast and repeated the challenge 8 to 10 days later. And 9 out of those 10 patients still had a reaction, but one of them had a no reaction at all. And this has now been reported a few other times, 2 different ways. This was a report we did with John Basso. 6 patients that had an initial negative challenge, and then we actually had them come back in again and removed the montelukast and repeated it, and all positive. But 5 patients also who had a very strong history, but despite withdrawing montelukast or zafirlukast and repeating the challenge, again, still were negative. And then in this study, they actually had 10, this is a Polish study, 10 patients that were challenge proven, and they basically did a super slow daily incremental increase. So starting at, like 10 milligrams of aspirin a day, and then every week increasing it to 20, and then 30, and then 40. And these patients actually were able to be desensitized without having any symptoms. So it seem as if it's possible to have these patients get desensitized, even though they truly have AERD, but not have symptoms or have very minimal symptoms. This is what we now recommend. If the patient has a negative challenge and you have a very high suspicion, you can do like what I just did in the patient I described. You can diagnose them with presumed AERD, keep them on aspirin, and just follow them medically. But ultimately, if it's uncertain, consider withdrawing them and doing a second challenge. I think that if the patient has a low suspicion to start with and it's negative, you can just say that they don't have AERD. But anytime that there's diagnostic uncertainty, you could consider having them come in for another challenge. And I think to complicate things even more, this is a report from Alina Gershow at Montefiore, and the question of what happens to these patients after sinus surgery. There was this sneaking suspicion that if we were doing these challenges right after sinus surgery, where we were starting to want to incorporate aspirin more protocolized by doing it right after surgery in an effort to prevent polyp regrowth. And so here you can basically see that patients that had their AERD reaction before they had their polyps debulked had a significantly increased amount of prostaglandin metabolite, marked decrease in that during the reaction after the sinus surgery. And if you looked at 18 patients who are challenge positive before sinus surgery, when you repeat the challenge 3 to 4 weeks after surgery, 6 of that group, or about 30% of them, did not react. So we now know that patients can clearly have AERD, but if the challenge is done shortly after sinus surgery, they may have a false negative challenge. And I think there's a hint of this looking the opposite direction as well, of how important the sinus disease is in terms of reaction severity. So we did a paper looking at our group for severe reactions, and these were patients who either required injectable epinephrine or multiple nebulizer treatments or FEV1 drop over 30%. And in that group, the people who had the most severe reactions, one of the only things that stood out in terms of our p-value was the baseline SNOT-22 score coming in. So the higher their SNOT-22 score, the more likely they were to have a severe reaction. We did not see that difference in the interval between sinus surgery, but this was not at all carefully looked at. So I think if we had been able to stratify a group, within 3 to 4 weeks after surgery versus 6 to 12 months after surgery, we may have seen the same thing that Lena Gershow had seen. So it does seem that what's going on in the sinuses has a lot of a potential effect on the outcome of the aspirin challenge or aspirin desensitization. What about patients that come in to us and they're already on a baby aspirin? So this came from the Brigham group. They had these 6 patients that all had come in being referred for severe nasal polyps and a question of whether or not they could have AERD, and they all reported, well, I'm taking a baby aspirin every day, so I can't possibly have AERD. So in this group, they withdrew the aspirin, they had them come in, and all of these patients had a positive challenge after they were withdrawn and went past their refractory period. So having a patient who reports that they're taking a low dose or potentially daily NSAIDs does not necessarily rule out the diagnosis of AERD, because they may have actually had a mild nasalocular reaction and when they first took it and then desensitized themselves and are no longer thinking that they have an allergy to it, right? Why would they? So this is a pretty good segue to come back to our initial case. So this was that patient had recurrent nasal polyps, difficulty preventing polyp regrowth, now getting ready for her next surgery. She can't drink alcohol. And she says that she takes NSAIDs without difficulty for joint pain. But when I actually asked her quite a bit more about that history of the NSAIDs, she actually plays soccer every single weekend, and she has quite a bit of joint pain. And so she reports that she takes an NSAID at least most days of the week and really doesn't go more than 2 to 3 days without taking something. So I thought that that history was still compatible with her having AERD, and potentially somewhere along the line she had desensitized herself. So we had her withhold all NSAIDs for 2 weeks. We had her come in for a nasal ketorolac challenge just to see if she had the disease. And she had clear asthma symptoms, a 7% drop in her FEV1, clear nasalocular symptoms. So really confirming that she had at some point desensitized herself and had just been unaware of it. She was going to be getting surgery, so we planned on having her come back a month later after her sinus surgery to do the full desensitization. And interestingly, in that setting, she actually had even a more pronounced reaction. She had classic, airway, upper and lower airways. But when we got to the 325 milligram dose, she actually had significant abdominal pain with vomiting. So this is, I think, a newer described AERD phenotype. These patients that have predominantly GI and dermatologic symptoms. So these are the patients that either describe to you or when you're doing the challenge desensitization, they have really intense epigastric pain, sometimes with vomiting. They often will have flushing. And in the Brigham group, they described this population as being very difficult to desensitize. And it's really primarily because of the intensity of these symptoms and the difficulty that we have in treating them. What they found is that these patients had an abnormal response to with their prostanoids. So if you think about prostaglandin D as being a big important mediator in terms of flushing, and we think it may have a big role to do in these GI reactions, what they saw is as you start to increase the dose of aspirin, the effect of the cyclooxygenase blockade should decrease prostaglandin production. That's the pharmacological effect. But in our AERD patients, it's also paradoxically increasing their PGD2 because that's being released from their mast cells and eosinophils. And so the curve here sort of goes out of the range of what we normally see in AERD, where we see this big surge of leukotrienes, but as soon as the COX-1 effect starts to take a hold, the PGD2 goes down quickly. And in these patients, it does not go down quickly. It's poorly suppressible. There's a much higher surge of PGD2, making us think that that's a dominant mediator in this particular group. This is an important phenotype to be aware of, because if you've tried to do desensitizations in this setting, everyone's miserable. The patient's miserable, and you're probably miserable too. It doesn't necessarily respond well to H2 blockers. It doesn't necessarily get prevented very well by the leukotriene modifier drugs. Potentially responds well to 5-lipoxygenase inhibitors, but we don't have any great data on that. So these patients can be tough, and they can be uncomfortable for 5 or 6 hours in the clinic, making it difficult to escalate their doses, and they have to come in and everyone's a little bit worried about it happening again. We are able to successfully desensitize them, but some of these patients, they may actually take 4 or 5 days in the clinic. So let me just summarize some of the pitfalls as we think about these patients. I think we need to be careful of patients where they have a silent desensitization and then we call it negative and tell them that they don't have AERD. And in that group, I think our patients who are on a leukotriene modifier drug appropriately to see if it helps their sinus disease or their asthma, and then somewhere along the line they take maybe ibuprofen for a headache. They don't really consider the fact that they got nasal congestion as an allergic reaction, and so they don't report it to anybody. If they're on daily baby aspirin or even regular NSAIDs for pain, then AERD still could be hiding underneath it. Some of the patients may tell you that they can't take aspirin because it causes severe GI problems, but you need to really characterize whether this is more of a hypersensitivity response or just the more low-grade delayed gastritis that a lot of patients may experience. And then you need to be careful when you're doing your challenge or when you're getting your history. Is there reactivity being measured immediately after surgery, where you might have, at least based off of the Gershow study, up to a 30% false negative challenge rate. So how can we do a better job? And potentially in that question is, should we be doing a better job, or does it really matter anymore? So number one, we need to have a higher degree of suspicion in our patients. I think most of that's going to be through history taking and then integrating what we know about their disease with any of the biomarkers that we can measure. And then also we really need some better diagnostic studies. So one of the things that can increase your suspicion would be these respiratory reactions to alcohol. So at the same time, about 10 years ago, Tanya Laidlaw and I had both noticed that most of our AERD patients would report to us that they were allergic to alcohol. And we never really thought much about it, but had a phone conversation and realized that, we both were noticing this, and it really seemed to be out of proportion to our other patients. And so we asked that question to AERD patients, a series of different questions, both looking at lower and upper respiratory symptoms. And actually up to 85% of patients with AERD would report that they would have trouble with alcohol. It's actually still more common than I would have thought in aspirin-tolerant asthmatics. And then in looking at patients with both CRS and nasal polyps, about 40% of the time patients would describe that. So although it does occur for sure in that background, it's much more common in patients with AERD. And it's a pretty intriguing when you look at the kinetics of what they describe. It's definitely something that's happening at a lower dose of alcohol, so less than 3 glasses in almost all patients. But about half the group of AERD would describe this occurring within just a few sips and within 15 minutes. So very, very fast onset. And obviously this is not something that's IgE mediated. It doesn't fit at all with COX-1 mediated, because we know that most of our patients are going to react really at more delayed, like 45 minutes to an hour. And also, there's not a COX-1 effect in alcohol, so you can't argue that point either. Most patients, it happens in less than an hour. A lot of these patients, it's such a troublesome symptom that they've either stopped or significantly reduced alcohol intake because it's just not worth how bad they feel. And I guess to make the point that this isn't a COX-1 effect is that desensitizing to aspirin, although it helps, it leads to improvement, is certainly not universal. So this really has nothing to do with the COX-1 pathway or aspirin. There's something different going on. There's a lot of theories out there. There's theories about tannins in red wine. There's theories about some of these other sort of volatile compounds. But at its core, this can happen even with straight alcohol and hard liquor. So it seems like it's something more ethanol specific. And I'm intrigued by this study. It's one of the only studies I could find where they got these mice nice and drunk. Just kidding. They looked at I believe this was a dust mite sensitization, not cockroach, it was a cockroach sensitization model. And so they got the cockroaches sensitized and then they gavaged them with alcohol and nothing really happens. But if you take those same mice and you sensitize them and you give them a low exposure to cockroach, just enough to get them inflamed, and then you gavage with alcohol again, you see a significant increase in inflammation. And I think this is the best paradigm to understand what's happening with alcohol, because it also would explain why some of our other asthmatics and polyp patients also experience this phenomenon. The intensity or potentially the quality of the inflammation seems to be uniquely sensitive to the effects of alcohol. And still, I don't think we understand exactly the mechanism there, but this is probably more a reflection of the state of the sinuses. So if you think about this as maybe a biomarker for the intensity of the inflammation, I think it starts to make more sense. And it may help us understand why some of our patients who get under much better control with either aspirin or a biologic or any other therapy, or even post-operatively, will report that their alcohol reactivity will go away or improve. What are some other things that we can use? So if you think about imaging, it's not a surprise here that the higher the Lund-Mackay score is on the CAT scan, so as you start to get up here to severe pan-sinusitis opacification, your probability of AERD increases significantly. And so if you look here again at these, this study, looking at that Lund-Mackay score, starting to see a cutoff here, maybe around 18 to 20, your likelihood of AERD increases dramatically. And this was a UVA study. I believe, if I remember right, Larry Borish told me that I think it was this patient here, one of these patients actually subsequently came in and had a challenge that was positive. So it actually had initially been put in this aspirin-tolerant asthma group, but ultimately was proven to be AERD. So what should we be using as we think about our patients? We don't have any really great diagnostic tests, so we should be incorporating the intensity of what we see on their CT score. We should be incorporating the need for repeat surgery and their polyp regrowth rate. So if there's a patient that's had polyps removed 6 months ago and they're coming back telling you they're already growing back, they're already developing anosmia, you need to ratchet up your suspicion. should be asking about alcohol reactions. In our EMR, I have a dot phrase, and so I actually have these factors included in my dot phrase just so that I think about asking them. I obviously asking about the significant amount of anosmia that they have. And then I'm going to go over with you a few other comorbid conditions that have more recently been reported. So most of this work has come from the Brigham group. They now have the largest AERD registry in the world. And they've now started to report on some other findings that I've seen in some of my patients. You've probably seen in yours. We see that involvement of the GI tract, specifically the esophagus, with esophageal eosinophilia now is not common, but I think more common in AERD than just in the average asthmatic. So that's something that should maybe raise the suspicion in some of your patients. This leukotriene rash has now been described a few times, and both seen during the desensitization, but also more spontaneously. And it was termed this leukotriene rash in part because it does seem to respond to xyluton. So potentially something along that pathway. Coronary vasospasm has been reported now multiple times. And in the AERD cohort at Brigham, when they looked back through finding patients that had evidence of some sort of coronary event, but without having significant atherosclerosis or needing a stent, in their AERD population, as many as 6% had that. And there's a case report of a patient with this responding to MEPOLIZUMAB, also suggesting that there could be a connection. And then also interestingly, premenstrual asthma seems to be enriched in patients with AERD. Up to a quarter of AERD women had this, and in their report, they also described that a proportion of women also would describe even perimenstrual sinus symptoms, which is intriguing. It makes sense, I guess, but intriguing that no one's ever really thought or looked for that before. In terms of diagnostic testing, we really don't have much. I don't have a slide here on urine leukotriene E4. It has been studied now multiple times. It's much higher in AERD than compared with aspirin-tolerant asthmatics or nasal polyp population. But unfortunately, the discriminating line that you could use, it still doesn't have enough sensitivity or specificity, I think, to be used practically to really make a decision. If you're doing aspirin challenges, I would encourage you to purchase this small device. So this is a peak nasal inspiratory flow meter. So we use this. The Europeans actually recommend using this in aspirin challenges. They use a cutoff of 40%. In our study, we actually found that a 25% drop in peak nasal inspiratory flow had pretty good specificity and sensitivity. And I think this is more important to consider using now that we really want to try to block the lower respiratory reactions. We want patients to be on a leukotriene modifier drug when we do the challenge. Nobody loves to have a patient have a 30 or 40% drop in their FEV1. And so you're going to potentially want to have some other diagnostic tools. So this is pretty helpful. We do this before each of our updosing or if the patient becomes symptomatic. So let's just shift a little bit, finally, my last few slides, to talk about where we are with our current treatment. You're all familiar with all of these treatments. I do want to just touch on diet and then touch a little bit on the biologics and where we are with that. So I'm going to just hit a few slides here. We've got one on omalizumab, one on dupilumab, and one on mepolizumab. So none of these are technically off-label because they're being used in that asthma population, but obviously there's not an FDA indication specifically for AERD. When we're looking at omalizumab, this work has mostly come out of Japan, where they've done a few different studies. This was the older study that was reported in JACI, and showing that with omalizumab treatment in patients with AERD, not only do you see significant symptom improvement, but you're seeing a significant drop also in some of the mediators that were being measured. So looking here at LTE4 and PGD. So maybe a targeted treatment for what we have going on underneath the surface in AERD. This was their most recent report, Blue Journal. I think it might still be in press or just out the last month or two. So this was a much better designed study. Their first group was not controlled. This was a controlled population that received omalizumab versus placebo, and then underwent aspirin challenge. And you can see that in the omalizumab group, they had significant protection from the surge of leukotriene and then prostaglandin metabolites that occurred during the desensitization. These patients also had significant symptomatic benefit, and a portion of them actually went on to have a second aspirin challenge that ended up being negative on omalizumab therapy, which also fits with David Lang's report from Cleveland Clinic a few years ago. This is from Tanya Laidlaw's group at Brigham. This was just looking back at the self-reported group of AERD patients that were in the landmark dupilumab studies for FDA approval. So this is not specifically looking at AERD. This is just pulling out of that of those studies, the AERD cohort. And ultimately, what you, I think, see is that there's benefit in all of the same measurements in AERD versus non-AERD, which makes sense. But I think if you look, even though it's not necessarily going to be statistically significant in all of these domains, the patients with AERD seem to have worse disease, so more room for improvement. Not necessarily, I think, that the medicine works better, but the delta probably is a bit bigger. So in almost all of these columns, you can see that AERD patients seem to start off a bit worse than their non-AERD peers, leaving there a little bit more room for improvement. So this is looking at Lund-Mackay score, the smell score, the upset score. This is polyps size over here. And then if you're looking at SNOT-22 score, you see similar. Patients with AERD seem to have a bit more impairment to start with, so potentially more, some more room for improvement. And then in terms of mepolizumab, so this was Brigham Group had done this. This is a retrospective series. They looked at all of their AERD patients who were on mepolizumab as FDA indicated for asthma. So this was patients who clinically merited this for the purposes of their asthma. So it's not necessarily representative of the bigger AERD population. In this group, you can definitely see that there was improvement in most of what they were looking for. So improvement in absolute eosinophil count, as you would expect. We do see an improvement in several patients with their SNOT-22 score, looking both at sense of smell and nasal congestion, and then overall with the entire SNOT-22 score. So some evidence potentially here for a beneficial effect of mepolizumab in that AERD population.
Andrew, do you hear me?
Yes, I do.
Can we go back to the omalizumab? I don't understand why omalizumab works in this disease. It has nothing to do with IgE. So why is that an effective therapeutic?
It's a great question. So you're right, it has absolutely nothing to do with IgE specificity. I think the question is, probably comparable is why does it work in urticaria? If this is not worked out, my hypothesis, and I think what most of us would say is this is having probably a dominant effect on mast cell signaling. And it's hard to pick a more important cell in AERD. Is it at the eosinophil or is it the mast cell or is it both maybe? And so I think I would look at it from that standpoint, is that the removal of IgE from the system probably changes some of mast cell functionality. And then that has the effect that we're seeing here. The other, I think, intriguing possibility would be whether there is more of a local IgE production in the sinuses, maybe directed against staph. And so I think that provides another hypothesis. But the short answer to your question is I don't know.
The people who are working with the new Siglec 8 which is a very effective, very important in mast cell and eosinophil. Do you know whether they're looking at that? I know they're looking at it in eosinophilic GI disease. Anybody looking at it here?
Not in AERD that I'm aware of, but they are looking at it in polyps, is my understanding. I'm not part of any of those studies. I do not think that anyone's looking at that in AERD specifically, where it would certainly make a lot of sense to look for it. You're right, because it would knock out both, right? Both mast cells and eosinophils.
All right, thank you.
Sure. I wanted to throw this in. You know, a lot of our patients are interested in non-medical treatment, and there's actually 3 reports in the literature that I'm aware of on diet and AERD. 2 of them are a low salicylate diet, which I think fundamentally doesn't make sense. So I'm not actually specifically going to talk about that. But this is a diet where the actual intention was to alter the omega-3 and the omega-6 pathway. And so if you enrich for the healthy omegas and starve the bad omegas, you're actually changing the ability of arachidonic acid to go down the inflammatory pathway. So you're sort of changing the fuel at the source. And a lot of the studies that have looked at some of these diet studies in asthma didn't necessarily look at supplementing with the good omegas simultaneously while dramatically decreasing the bad omegas. But they did that in this study. And they were able to show not only was the omega ratio significantly changed, they were able to show that there was a decrease in the inflammatory arachidonic acid metabolites and an improvement in symptoms. So this was definitely a positive study. It was a small pilot study. I think the problem with this, and what I go over with patients, is this study, the diet was so intense, the amount of supplementation and the amount of foods that needed to be avoided, that most patients actually reported that they wouldn't continue the diet long term, even though it seemed to be beneficial. So, you know, we don't know whether maybe a less rigid diet would provide similar benefit. But for patients who are really interested in pursuing, you know, more of a natural treatment, I encourage them along this path, not necessarily a low salicylate diet. And if you're interested in that, actually the dietary approach is described in that paper. So you can pull it up and go over it with your patients. So my summary here, AERD is definitely less common than 20% of our asthmatics, but I still think it's more common than you think. Maybe not than you on the line here, but certainly when we incorporate our ENT and pulmonologist colleagues in primary care, these patients we know for sure are hanging out there. If we had the ability to ask the right questions or screen better, or, you know, I think we would find that more and more patients have AERD. We know that you cannot diagnose AERD properly on history. You're going to miss it. I think you can come close though if you ask the right questions, if you include things like alcohol reactivity, polyp recurrence rate into your history taking. We know that AERD patients really have a very high burden of illness and a lot of unique characteristics. And I think that's the point of why we should still be looking for them. I think in the era of our biologics, you could say, what's the point, right? That was actually in our New England Journal paper that Don Stevenson and I wrote. One of the letters that came back in was, you know, why does it even matter to diagnose AERD? Because we're just going to put them all on a biologic. And I don't necessarily think that's the right answer. There's, you know, a lot of pros and cons to how we treat our patients. And I think ultimately we may find that there's characteristics about AERD that give us the ability to give a much more targeted treatment. And potentially in the next 5-10 years, we'll even be able to have biomarkers that'll help predict patients that respond to aspirin versus, you know, omalizumab versus Dupixent or some of the other therapies. And then I do think, though, that biologic therapies have now become a bit of a disruptor for our current paradigm. You know, before we were putting everybody on aspirin because it was one of the only options that we had. Now we've got a lot of other options, and this is providing us with a lot of opportunities for research as we figure out how do we take this back to our patients. So I'm going to end there. I've got my final slide here for the word of the day, and I'm happy. Got a few minutes for questions or comments.
Thank you very much. I have a question. Something you went by pretty quickly, but that I thought was intriguing. It was a slide where you showed the Great Wall of China.
Yeah.
You alluded to the fact that T biology, let's call it, was different between Asians and Western Europeans right here, which is nothing I knew about, but would seem to be tremendously interesting. So can you expand on that?
Sure. So this was, I guess I've got the reference down there. So a little while ago now, this was a larger international study. I think it included Northwestern, the Belgium group, and then a group in China, where they were primarily just phenotyping the polyps, looking at neutrophil content, eosinophil content, because I think up until that point, there was this idea that all polyps were eosinophilic. And now I think, the more and more of these studies that come out show that even amongst polyps, there seems to be a fair amount of heterogeneity in terms of the underlying inflammatory milieu. But what they really found was that this was quite a bit different when you looked at ethnic Chinese patients from China and you compare them to these European populations. And I don't think it's clear at all whether this is really an environmental factor, whether it's effect on pollution or air quality differences, or whether it's really the genetics behind it. But it's definitely been seen now a few different studies, and at least in terms of AERD, it really fits nicely if this is one of the only populations in the world where AERD doesn't seem to be common. And then at the same time, we're seeing that their polyps tend to be a lot less eosinophilic.
The other question I had, which is not specific to, well, actually just one comment first, showing us that there are a lot of manifestations that are not respiratory. Is this going to have to just be renamed aspirin-associated disease?
Potentially. We're already struggling with the name because the Europeans want to call it NERD. So I think throwing another name is going to be too challenging.
What do they want to call it?
NERD.
What does that mean?
They want to call it NSAID-Exacerbated Respiratory Disease. And so the acronym for that is NERD, unfortunately.
The thing I was going to ask is, although leukotriene biology is very important in this disease, and anti-leukotriene therapy is useful for the broader population that we deal with, all of us with atopic disease, I've found these drugs to be disappointing and also disappointing that no one has ever come up with a better one than montelukast. There's really no further investigation in that whole area, even though there was a Nobel Prize given for understanding what leukotriene biology was. Why do you think, or maybe you don't agree with me, that leukotriene antagonist drugs have not been a great success overall in respiratory atopic disease?
Yeah, I totally agree with that. And even in AERD, I would say the effect is underwhelming, at least for the receptor blockade. I think we know less about xylitol. It's just not been studied nearly as much, but potentially there's a bigger effect. And maybe that has to do with the more recently described LTE4 receptor. LTE4 seems to have its own, pathway, its own receptor. And so if we're focusing just on, blocking cyst LT1, we're potentially missing that. So I think that's potentially one, is that we've had an incomplete awareness of LTE4 and its effect. And then, but I totally agree with you. I think that there's even studies that show that the effect of montelukast in AERD even isn't that much better than in regular asthma. So it's very common in my AERD population to try montelukast and have it not be effective. I would say that a lot of the recent studies are really pointing towards PGD2 as a very dominant mediator in AERD, and that actually may be part of the explanation for the benefit of aspirin now, is just simply because it's going to downregulate PGD2 long term. And so maybe that's actually part of the reason as well. It's even though it's been so important in our understanding of the aspirin reactions to look at leukotrienes, it's probably less important in the day-to-day disease. That's my take.
Question?
Yeah.
Is there any role of epoxides in the AERD? I got that feeling Stevenson thought so about 15 years ago. I haven't heard anything since then.
That was, I think there is a role. It fits into the dysregulation of that pathway. And I believe there was a study from Scripps looking at that, maybe 10 years ago. I don't think there's anything really recently. So my gestalt is that it's really sort of thought to just be part of the whole dysregulation, but not maybe a dominant part of the puzzle.
Thank you.
Yeah.
Any other questions this morning?
Can I ask a question of your group? So you just had the ENT colleague. Did you find any big sort of discrepancies or different paradigm in what they shared with you with what I shared with you?
Well, that was 2 weeks ago. I'm not sure I can remember back that far back. Can anybody who's young and smart remember that? I think the answer is generally no.
Okay.
I know, Greg Davis, are you still listening?
Yeah, I'm here, Len. Hey, Andrew, I've seen you talk before. Thanks for being here. It's always nice. I'm one of the ENTs up in Greater Seattle. Walid Abuzid, he did a nice talk a couple weeks ago on AERD from an ENT's perspective. Very, very similar. I really liked your approach, though. It was nice and clear, I thought. So thank you for that.
Okay.
My question, since I'm on the screen, I have for you, there's always a bit of a debate between when to do the desensitization post-op. And clearly, I think your presentation showed we should be testing for aspirin sensitivity before surgery. I'd love to know your opinion, why you think that changes the sensitivity pre versus post-op. And then the second question is, how soon after surgery, this ongoing debate of what's the ideal time to do desensitization?
Yeah, that's a great question. So, I mean, I think the reason the reaction decreases probably is just literally removing so much inflammatory tissue that's fueling the reaction. It sort of argues that you require that sort of background fuel source in the sinuses to create the leukotriene and eosinophil surge. So I think that's intriguing. It also sort of fits in with patients not only feeling like they can breathe better through their nose, but actually having, significant improvements in a lot of their other aspects of quality of life by getting the polyps debulked. In terms of the timing, so most of the studies, when I showed you those randomized double-blinded studies, they show improvement in polyp growth rate. We don't see regression like we see with a lot of the biologics or with some of the biologics. So, once you've got big bulky polypoid disease, starting the patient on aspirin at that point is probably not going to give them as much benefit. And so I think whether you do it 3 to 4 weeks after surgery or 2 to 3 months after surgery is probably not that big of a difference. So our target, we usually plan for 4 weeks after surgery. just because we know that that's sort of a good time where they've mostly healed up and we, are nipping it in the bud in terms of polyp regrowth. But I don't think, there's no studies on that. It's just sort of the general consensus.
Appreciate it. Thank you.
Yeah.
Anybody else out there with a question for Andrew before we let him go? Well, if not, thanks very much for joining us. It'll be interesting to have this talk again, and as biologics emerge, if this disease is a completely different issue in a year or two.
Exactly. We're going to learn a lot. Yeah. Well, I really appreciate you having me.
Go enjoy the sunshine.
Thanks. Stay safe.
Okay, bye-bye.
Bye-bye.
Thanks, Drew.
Yeah.